Hello, good afternoon, good evening, good everything wherever you are, and welcome to today's webinar. If you're joining us, let's know where you're joining us. Let's know where you're from. Let's know. Oh, thank you. Welcome, everyone. Welcome. Thank you for joining us for today's stream, today's webinar. Let's know where you're joining us from. Let's put it in the comment section. Today is going to be loaded. It's really loaded. It's powerful. And I'm glad that you're here. Thank you for taking out time to be a part of today's conversation. Please, if you're online, if you can hear me loud and clear, let me see. Put in the comment section, say I can hear you, and tell me where you are joining us from. If you can see and hear me, let me know, please. Let me be sure I can be heard. Opelua, thank you. Thank you for confirming that. Opelua, you're welcome. You're welcome. You're welcome. Our guest speaker is in the building already, and she's no stranger to us. If you were here during the thank you, Opelua. If you're here during the Women's Day program we had about a couple of weeks ago, I'm sure you'll have heard her speak. And based on popular demand, we couldn't get enough of her that day, and people are like, no, we need more of this kind of session. So we just thought, you know what, we just have to bring you back. And thank you so much, Doc, for the special honor and privilege to have you back on the show again. Thank you so much for your time. We do not take you for granted. So I have in the building the one and only Dr. Anu Adetono. And before I play her bio, before I introduce her, I'd like to do like a quick run through of PSP. I'm still waiting for more people. Let's know where you're joining in from. Let's know. Don't be shy now. Okay, let's see where you're joining us from. Only
Adetono is a
where
highly
she's joining
experienced
from.
GP.
I need more people. Let's see. Okay, so while we wait for more people to put in the comment section, I'm just going to do a quick run through of PSP. So PSP is parents. Bolu, thank you. Manchester. Oh, nice one. Thank you. So PSP is parents supporting parents in the UK, and our vision is to empower the Nigerian parents in the UK to thrive in a diverse society while raising awesome families and fostering a sense of community. We all know how our community is really important to us as Nigerians. And traveling abroad, being in a place where you're far away from your families, and sometimes you get lost, like you feel like you're the only one in this. But I'm glad to announce to you that you have a family in the UK. So we are a community. We raise awesome families and we foster a sense of community. And our tagline is we are here to support each other while raising strong families. Over the years, we've been able to, through collaboration and advocacy, we've been able to equip the Nigerian parents with the tools, the knowledge needed to navigate the challenges of parenting in a new country. I'm sure you will agree with me that it's not easy raising kids in the UK. And that's why the community is there. If you have any questions about anything, finance, family, parenting, just name it, food. I mean, you can, the kind of questions we asked, anything, and thank God we have a very robust community, and we have knowledgeable people who are always willing to provide answers. So our core values are respect, empathy, mutual support, education, advocacy, and community engagement. And over the last few years, over the last 1 year now, we have had topics, webinars around different topics, varying from how to care for your skin to education, understanding the British education system. We've had topics around finding yourself in the business of life, about how to raise how to raise girls in this community. We've had about sex and marital pleasure. I mean, how to enjoy your marriage. We've had a whole lot of webinars, including how to transition to tech. We've also had about insurance, mortgage. So you see that it's all encompassing. We don't only talk parenting matters. We deal with every aspect of our lives. And other activities we have intercessory prayers. The truth is, no family can grow without prayers. There's Our knowledge is still limited, so there are some things that we need to still download in the supernatural realm. So we give time to intercessory prayers where we pray for families, we pray for churches, we pray for the community. Then we also have the Bible club. We have monthly prayer meeting for our families where we just dedicate time just to pray for our families. And we also have webinars, of course. This is one of them. And our upcoming activity, we're planning a charity project by the end of the year and also a summer hangout. So watch out for that. All right. So if you love what we are doing and you're like, you know what, you guys, I'm interested in partnering with you, I'm interested in collaborating with you, we have some contact details there, and that's our email address. Please do well to reach out to us. And if you know someone or you are someone, probably you just stumbled upon the link and you're like, oh, I'm in the UK, I would love to be a part of this kind of community, you can scan the QR code or use the link there. But note, we only admit people with UK lines, and that's just for security reasons. All right, thank you. So now I'm going to be playing the bio of our guest speaker, the one and only
medical practice in the United Kingdom.
Dr. Anu. So please sit back
Dr.
and watch. And the next voice you'll be hearing after this would be Dr. Anu herself. Thank you. Thank you.
Anu Adetona is a highly experienced GP with over 10 years of medical practice in the United Kingdom. A graduate of the University of Liverpool Medical School, she is dedicated to providing comprehensive patient care. Currently, Dr. Adetona is a GP partner at Denbridge Medical Practice in Northwich, where she leads quality improvement and clinical audit initiatives. She also runs a weekly family planning clinic and has a special interest in women's sexual and reproductive health, along with menopause management. Join me in welcoming Dr. Anu Adetona.
Thank you so much. Thank you so much to the PSP UK team for having me. Thank you so much for everybody who is joining in today. So I'll be talking today about menstrual disorders, infertility, and menopause. And I've been given a lot of time to talk about this topic, so I'm going to go into a lot of detail. Okay, so I want to say again, I count this a privilege to be speaking to everyone today, and I thank you so much for everybody who's joined in. So I have to say I'm a doctor in the UK, which means that everything I'll be talking about today, especially the treatment, will be in accordance with the UK medical guidelines. So if you happen to be connecting from a different country, just know that the treatment guidelines that I'll be talking about today will be, UK based. However, you'll find similarities. It doesn't matter where you're listening to us from. And all the things I'll be talking about today, they're women issues. Okay, so it doesn't matter your race, your nationality. I'm hoping that you'll be able to relate to the stories that I'll be sharing. I'll be sharing some of my personal stories. I'll be sharing some of common things that women come to me about, and then I'll talk about sort of the symptoms to watch out for and when to see your GP. I'm really hoping that I'm able to empower women, because that's the main thing. I want you to know your body, know when something goes wrong, and know when it's time to see a doctor. Okay, and I'm going to be going into a lot of detail, so please, I don't believe this talk is appropriate for children. It's for adults, and by all means, if there are men here listening, you can just send the link to your wives, because I'm talking mostly about women issues. Okay, so I'm going to start off with menstrual disorders, and I think it's always important to know what is normal. So that's what I'm going to start off by talking about: the menstrual cycle, what is considered normal. So girls usually will start menstruating between the ages of 10 and 13. And some of you might be thinking, well, I started a bit earlier. It's okay. Again, this is the average age, the age range. Okay, some girls might start at 9, but I have to say, if you find that your daughter is starting at 8, that's quite early. So I will take her to the doctor to have a conversation. Okay, and then some girls start a bit later, but again, this is the average age. Okay, and the average age in the UK of menarche is the age where a girl starts her period. The average age in the UK is 12 years. Periods can be irregular initially. So when you first start your period, you might find that it's, here and there, it's all over the place, but there's no need to be concerned. However, if it continues to be irregular for the first or second year of your period, then it's good to go see the doctor. Okay. Now, on average, your period can last sort of 3 to 8 days, usually occurs every month. So every 38 days. You have some women say it's a bit longer than that. It could be every 35 days. But over time, you start to know what is normal for you. A woman can lose up to 80 mils of blood during her monthly period. Now, 80 mils is quite generous. Most people lose less than that, okay? But this is just an idea of what is considered normal. So up to 80 is considered normal. Some women experience period cramps due to contraction of uterine muscles. Again, to an extent, period cramps are not unusual, but we'll talk later about what is abnormal. Okay. I'm going to take you back to your biology class, and I'm going to, I don't want to spend too much time on this slide, but I think it's really important that we know what's happening in our menstrual cycle, so that we have a bit of an understanding, because most of us might have forgotten what we learned in biology. So during the menstrual cycle, I want to start with menstruation and what happens. So during menstruation, your hormone levels are actually quite low. So the estrogen levels are low, progesterone levels are also low. And during that time, most women just don't feel ourselves. And what's happening in our uterus is that the uterus lining is quite thick. And during menstruation, we're shedding that blood. Okay. So most of us might feel might get bloated, you might have the tummy cramps, you might just feel a bit tired and rubbish. And a lot of it is because of the hormone levels are low. Your periods might last again 3 days or 5 or 7 days, and then you get to the point where your estrogen level starts to pick up again, and you feel higher energy. If you're married, you might find that your sex drive is higher at that time, and it's because the hormone levels are high. And I always just think how amazing God is and how intentional God is. The reason why you feel so great sort of during that time period is because your body is now getting ready your ovary is getting ready to release an egg. And the whole point of this cycle is, if you're married and you're trying to have a baby, when your ovary releases that egg, that's the optimal time then. So ovulation, for you to meet with your husband and for sort of the sperm to travel and meet the egg. And that's very likely why you feel so great, because what you're supposed to be doing at that time then is baby making. And then you have ovulation. This is when the ovary then releases an egg, okay? And each month, a woman's ovary will release an egg, and the hope is that it'll become fertilized. Now, if you're not married or you're not at that point where you want to have children, what happens is there's no fertilization, okay? So at this point in time, the estrogen levels start to go down again, but your progesterone level increases. And progesterone is the hormone that helps to build up that uterus lining. Because if, for example, you did, you had sex with your husband and then there was fertilization that occurred, then your uterus lining needs to be thick so that the embryo can implant in the uterus, and so that the fertilized embryo can remain stuck on the uterus so that the pregnancy can start to grow. So that's basically a summary of what tends to happen. And if you can see the slide, it shows different symptoms that you might experience. For example, during ovulation, a woman might find that vaginal discharge is now a bit thicker and a bit stretchy as well. This is all in keeping with the cycle and what's supposed to be happening. Okay. And then we're going to talk about some scenarios. So throughout my talk today, I don't want you to feel like you're in medical school or you're in a science class. I want it to be quite conversational. So I'm going to be sharing my personal stories, and also I've put some stories, some scenarios of patients that I've met and who have obviously come to me as a doctor for medical help. Okay, now they're all anonymized, so they're not real people, but I've kind of summarized or group them into different sections so that you find it more relatable. So I'm hoping that even if you yourself have never experienced something like this, you will have a sister, a cousin, or a niece or an auntie who might have experienced something like this, so that you can be aware of the symptoms and you can guide them and tell them, okay, I think it's time for you to see a doctor. So I'm going to share my own story here. And I started my periods when I was 10 years old. And I remember that year, my mom, earlier in the year, my mom had told me about periods and what to expect. I don't remember her mentioning pain. So I was very surprised when I just, she dropped me off in a friend's house, and I got the most horrendous pain that I ever experienced as a 10-year-old. And I was just wondering what's going on with me. And I started vomiting. I had diarrhea as well. And then I saw blood. Now, I wasn't too shocked because my mom had told me what to expect, but I didn't know it was going to be this painful. And I thought, when I spoke to my mom eventually, she said maybe it will be just a one-off. Maybe the next one will not be as painful. But unfortunately for me, every single month was, I was in pain. I was missing school sometimes. Even when I would go to school, I would end up in the sick bay for most of the day. So for me, period was not something that I enjoyed. I didn't look forward to it. And I found that I was always very tired and drained. I couldn't stand up I couldn't stand up, vertically. I had to always lie down. So and that was because I was just so drained and I was in so much pain. So I want to share a bit about Florence's story. So this is, again, a scenario that I've made up that I'm hoping that somebody can relate to. And I'll share later on what I did and what helped me to battle or to, get me through period pains. So Florence is 24 and she comes to see me. She has very heavy and painful periods. Her periods tend to last 7 to 10 days and they occur every 4 weeks. Every month she has to take time off work because of her symptoms. She's feeling very drained and very tired. So for those of us in the chat, for those of us who are listening to me who have experienced period pain or any kind of symptoms that I shared or Florence might be experiencing, please just type it in the chat, oh, this was me, or, this was my sister, just so that people can see that, it's very common. And I want to make sure that you're relating to what I'm saying. So if somebody like Florence comes to see me as a GP, I want to ask her a few more questions. For example, has she always had painful periods like I did, or did it just start later on in her life? And I want to know, so she mentioned it's very heavy. Is it heavy all through the 7 to 10 days, or is it heavy for the first couple of days? So I need to ask a couple more questions. And usually I always want to examine my patients as well. But sometimes examinations are not always appropriate. So I'd always offer that to Florence. So do you mind if I examine you today? And depending on what she says, if she's bleeding heavily, then I won't bother. But these are some common things that we go through. And I can see someone say, Judy saying, this was me. Yes, I'm sure there's so many people that can relate to this. So let's talk about the causes of period pain. So on the left-hand side, you can see painful periods. On the other side, we'll talk about heavy periods. So painful periods, there's a medical term for that. It's called dysmenorrhea. And there are two different types. There's the primary dysmenorrhea, the secondary dysmenorrhea. What I had was considered primary. And the reason for that was because primary dysmenorrhea means that there's no pelvic pathology, which means that there's no obvious cause. I remember having a scan probably when I was about 20 or 21. I went to my GP, they organized a scan and there was nothing. They couldn't find anything. So with primary dysmenorrhea, we don't always find a cause. It just happens. And if we think about it physiologically, there is a hormone called prostaglandin, or it's something that's released when we're going through our menstrual cycle. And what happens is prostaglandins cause smooth muscle contraction. So what's happening basically is that when that is being released, your uterus is contracting, and it also acts on other smooth muscles, like in the gastrointestinal tract. So that's why some women will vomit, like I used to do. Some women experience either tummy pains or also diarrhea. Okay, it's basically because of the prostaglandin production. So that's what used to happen to me. I would vomit or just be, basically I just couldn't do much, during that time. And I'm sure some women, have experienced things like that. So secondary dysmenorrhea, this is when there's an actual reason why this person is having pain. It could be fibroids. It could be because of endometrial polyps, endometriosis, adenomyosis. These conditions I will talk about later through the conversation today. Ovarian cysts. Now, not everybody who has ovarian cysts has pain. However, some women will have very large cysts that could cause them pain. And then you have pelvic inflammatory disease as well. And even sometimes the IUD, which is a form of contraception, the copper IUD can sometimes cause women to have more painful periods or even heavy bleeding. So what can we do? So again, when women come to talk to me about when patients come to talk to me about their pain, I always feel for them, because something that I went through. I always make sure that they've tried some painkillers. So I think even before you go to the doctor, it's a good idea to have tried some paracetamol. If you can take ibuprofen, then try those things. And then if it doesn't work, again, it's time to go to the doctor. I used to use a hot water bottle, which was helpful for a time, but again, it wasn't taking the pain away completely. There's something called the TENS machine, which you can actually buy either on Amazon or any of the shops, and it helps with pain. I have a friend who used that during labor, and it really helps. So again, that's something else that you can use for pain. Okay, when you go to the doctor, if you've already told them that you've tried paracetamol, you've tried ibuprofen, there's some stronger painkillers that we can prescribe. For example, there's one called naproxen, which is like ibuprofen, but it's stronger. And then mefenamic acid is another one that my doctor gave me, and it helped. Okay, but I have to say with mefenamic acid, because it's an anti-inflammatory and has some long-term effects, a lot of doctors don't like prescribing it long-term. Okay, so let's say you've tried all these things. The next things that we have to start considering will be hormonal contraception. And you might be saying, well, I want to have children, so contraception is not going to work for me. And that's why it's worth going to the doctor and have a conversation. So I don't offer contraception to everybody. I need to take a history and find out what they want, So, but contraception can help. And what it does, what the contraceptive pill does, it reduces that prostaglandin production. So that thing I mentioned that causes contraction of the uterine muscles and contraction of smooth muscles, the contraceptive pill can reduce the production of that, so that the woman doesn't experience as much pain. Okay. Now I put IUS there as well. That's an intrauterine system, which is a hormonal coil that can also help because it helps to reduce the bleeding, which in turn reduces pain. Now, let's say a woman has had a scan, and I always tell women who are listening, the reason why I'm giving this talk again is to empower you so that you know when something's wrong. If you go to your GP and they try you on mefenamic acid or something else and it doesn't work, then please go back. Okay, you need to go back, and if they haven't given you a scan, then ask them for a scan. And if they find something, then we have to treat the cause. If it's a fibroid they find or a polyp, then at that point you need to be referred to a gynecologist to have it removed or sorted out. So in Florence's case, she had secondary dysmenorrhea that was caused by something, and let's say in her case it was she had polyps. So I referred her to the gynecologist, and she had the polyps removed. Now, heavy periods. There's a medical term for that, and it's called menorrhagia. And there are different reasons why women might experience heavy bleeding. Idiopathic means we don't find the cause. You have to understand that as doctors, we try to find things, but sometimes we just don't find it. So it could just be idiopathic. But again, some of the same causes of painful periods also cause heavy periods. And if you go through the list, you can see that. So endometriosis, adenomyosis, hypothyroidism, pelvic inflammatory disease, some medications can cause that. Hormonal contraception can actually cause heavy bleeding and even cancer. So what are the treatment options for this? Again, you're thinking of, as a doctor, I'm wanting to try hormonal contraception. In the UK, the IUS, which is the hormonal coil, is actually the first line treatment for heavy periods. Okay, the brand name here is Mirena. So that's the one that we commonly use. And you will hear me talking about the Mirena a lot of times throughout this conversation. Or you can even try some contraceptive pills. But the Mirena coil is the first line treatment for heavy periods. Now, in some women who are not ready to have children yet, they don't want contraception. So I need to come up with, as a doctor, I need to come up with other treatments for them. And that's where tranexamic acid comes in. This is a tablet that they take in the first couple of days of their period, and it helps to reduce the bleeding. But it doesn't fix everything, because it only reduces the bleeding, and next month they're going to have to take that medication again to help, reduce the bleeding. Some women come back to see me and say it didn't really work. So this is when I need to obviously examine. I would have examined them already when they first came to me. If they were not bleeding heavily, I would have sent them for some blood tests, because again, in Florence's case, she's feeling drained, she's feeling tired. So it's making me think, is she anemic? Is a hemoglobin level fine? Which is why I would do a blood test for her to check her blood count. Okay. And then if she's anemic, it depends. How bad is the anemia? I had a patient about 2 or 3 weeks ago. Her hemoglobin level was 7.4, which is very low. I had to send her to the hospital to have a blood transfusion. So women, this is no joke. It can be really bad, where you get so drained, you're losing so much blood, and you need treatment. So please make sure you go make an appointment with your doctor if you're experiencing very heavy bleeding. Okay. So let's say tranexamic acid doesn't work, and I send her for a scan. If I find something on the scan, then we need to treat it. If it's a polyp or a fibroid, then I need to refer her to the gynecologist. And the gynecologist would have suggested, most times when they go to see a gynecologist, they always suggest the Mirena coil first of all. So that's even the first thing that the gynecologist would mention. So that's why I mention it before I even refer them, because by the time they go to the gynecologist, I want them to be thinking of something else. Okay. So for some women, they might have to have an endometrial ablation, which is basically where they scrape the lining of the womb so that it doesn't get thicker every month. Or some women have to go down the drastic route of having a hysterectomy, which is where they remove her uterus. Okay. But that's always the last case, the last scenario. We don't go straight for hysterectomies. We want to try other things first. Okay. So we've talked about painful periods and how to manage it, and I've talked about heavy periods and how to manage them as well. So let's go on to our next patient, or the next female, Hope. So Hope is 33, she's a lawyer, she's fit and healthy, goes to the gym every day after work. Her period stopped 5 months ago, and she thought it was due to stress, but now she's worried. So I have to say at this point, it's really important that you know what's normal for you, so that when something goes wrong, you know when to seek help. Now, her period stopped 5 months ago. Sometimes patients will come to me and say their period stopped just 1 month. So they missed one period. At that point, I'm not too worried. So what Hope has done is that she has waited a bit longer, because she doesn't want to go to the doctor and they just tell her, well, it might just be, women miss their cycles all the time. Maybe you're stressed. So she actually waited 5 months. Now, I would probably say, I think 2-3 months is enough to wait. And if nothing's happened, nothing comes back, then go and see your doctor. But she waited 5 months. She put it down to stress, but now she's getting worried. So we're going to talk about women that have irregular or infrequent periods. And that means periods that don't happen monthly. Like I mentioned, it's normal for you to have a monthly period. So if you don't have a monthly period, please, you need to speak to a doctor. Some women, when they're still young, before they get married and want to have children, they know they have infrequent or irregular periods, but they don't do anything about it. And it's then when they get married and they want to have a child and they're having difficulty, then they come to the doctor, and I'm asking them, oh, so how long have you had this problem? Oh, since I started my period. That's not right. You should, if you know that you have a regular period, just know that it's not normal. There must be a reason why your periods are not regular or why they are infrequent. So don't wait until it's time for you to start, trying to conceive. That should not be the time when you're now seeking, running up and down. This is the time before you actually maybe get married, before you start to have children. I want to just put that in your mind, so that if you have a sister or somebody that who's experiencing irregular periods, before they even get married, that should be the time when they go start to seek help. So there are many causes of this. For some people, it's because they're stressed, because they've lost weight, because they exercise a lot, because they're on contraception, okay, or they might have an imbalance of hormones, or they might have PCOS, which is very, quite common, and I'll talk about that later on. Or it could actually be perimenopause. So please see your GP for tests. For me, when a patient comes to me, if I've done all the blood tests, checked all the hormones, done all the scans, and I don't find anything, some patients will just say, well, doctor, you didn't find anything. That's fine. I don't think it's fine. I usually refer them to a gynecologist. Okay, let's try our best to try and find out what's going on. And if a specialist tells you, actually, that's just the way you are, then okay, So let's move on to amenorrhea. This is when you don't have a period. Okay, so I mentioned earlier that in a girl child, usually your periods will start about 10 to 13. If you don't have any period at all by the age of 16, that is called primary amenorrhea. So it means that there's something going on that didn't cause you to start have your period. So again, you need to go to the doctors about that. Now, secondary amenorrhea is the absence of periods for 3 to 6 months in a woman who used to have a period. Okay, so she used to have a period and all of a sudden it stopped. She's waited 3 months, nothing's happened. Go and see the doctor. Again, different causes. Imagine you might be pregnant. Pregnancy is one common cause of secondary amenorrhea. So I always would ask the woman to do a pregnancy test to check if she's pregnant. It could be stress again, weight loss, exercise. It could be some contraceptives. For example, the mini pill can stop your periods. The Mirena coil can stop your periods. And usually when your doctor prescribes those things, they will tell you that your periods might stop. So if your periods stop, you don't have to come back to the doctor. You know that it's because you're on the pill. It might be an eating disorder. It might be endocrine issues. It might be premature ovarian failure. It might be menopause, which again, I'll talk about later. So if you don't know what caused this, please go and see your doctor. Because if a woman is not having periods, then it might be difficult for her to conceive. So please see your doctor to find out why your periods have stopped. So in Hope's case, it was because she was very stressed. She's a lawyer, very stressful job. She wasn't really eating much. She had lost weight. Exercise is always a good thing, but some people overdo the exercise. Okay, so when I saw Hope, we did blood tests, we did a scan, everything was normal. I encouraged her to improve her diet. I encouraged her as well, to take some time off work, and all those things helped. Okay, and then I saw her again 3 months later, her periods had returned. So in that kind of scenario, we know that, again, things are fine. And it was because she was under stress, which she has now sorted out. So let's talk about Fatima. So Fatima is 26. She experiences bleeding in between her periods and after exercising. Now, Fatima is a virgin. She's been invited for her cervical smear, but she does not attend the appointment because she thinks that it's only for women who are sexually active. She's worried about her bleeding pattern, so she makes an appointment with her GP to discuss this further. Now, in the chat, because I've mentioned something about cervical smears, in the chat, please, women, what are your thoughts? And men too. What are your thoughts about having a cervical smear if a woman is a virgin? In the UK, once you're 25, you will receive a letter inviting you for a cervical smear. But I find that some women just assume that it's not for them because they're not having sex yet. So please, in the chat comment, just write what your thoughts are. Do you think it's okay to just ignore the smear and don't go for your smear because you're not having sex? Or what do you think? Let's find out. So with Fatima, I'm always very conscious when a woman comes to see me. I'm always very conscious of their cultural background and sort of, just trying to make sure that they feel comfortable with me. So already I can see Fatima she's wearing a headscarf. I'm not sure if she will allow me to examine her. So I always try and make the woman feel very comfortable. So I'll be asking her some questions. If she's having bleeding in between her periods, this means she's having bleeding when she's not supposed to be bleeding, and also after exercise. So I want to find out what's going on. I will need to examine her because it might be a cervical polyp that I can see when I do the examination. But if she doesn't allow me to do that, then it's going to be difficult. Okay, so with her, I'm going to ask more questions, and then I'm going to find out how she feels about examination. Okay, so with Fatima, I would say something like, Fatima, this condition that you have, it could be a cervical polyp. I'm not sure what it is, but I need to examine you. How do you feel about me examining you? And I will wait for her response. She might say, oh, I don't feel comfortable with that. And I'll say, that's okay. But I'll explain that at some point, we're going to need to examine her so we can have a look. And I might ask her what her fears are. Some women might assume that the speculum that I use might cause her to lose her virginity. They might be worried about things like that. And I have to explain that we do have small speculums, We even have virgin speculums that will not break the hymen. So once I can explain all these things to Fatima, the hope is that she will either say, okay, or she might say, actually, I still don't feel comfortable. And I might tell her that I'll let her think about it. In the meantime, I can send her for a scan or send her for some blood tests, and I'll see her again in a couple of weeks' time. Now, with ultrasound scans, we can do ultrasound scans using the abdomen. Sometimes we don't see much. So that's why some women might need to have a transvaginal ultrasound scan, which means that she might still have to have a scan inside her vagina. So I need to explain all these things to her. And then if she doesn't feel comfortable, I might ask her to come back and see me in a few weeks' time. And I think for healthcare professionals, I just want to make a plea that some women don't come for their smears because they had a bad experience. It's so important for us to make women feel comfortable. It's important for us to take our time to explain the need for these tests, okay? And the same goes for patients who might be autistic. We just need to take some time to explain things and not just feel like they're being difficult. So I had a smear recently and the nurse was just so nice and she took time to explain things. In fact, I was so relaxed by the time she did the procedure. And once you're relaxed, when you go for your smear, it makes everything much easier for the nurse or for the doctor who's doing the smear. Okay, so let's talk about the different causes of intermenstrual bleeding. So intermenstrual bleeding is bleeding that occurs outside of your menstrual cycle. And there are different causes of intermenstrual bleeding. It could be sexually transmitted infection. It could be infections like Candida, which is thrush, or bacterial vaginosis, which is BV. It could also be spotting due to the hormonal contraceptive pill or due to the IUD. It could be cervical ectropion, which is not as severe as it sounds. It's just when there is some redness on the cervix, and a lot of women experience this. It could be a polyp. It could be the worst case scenario would then be some kind of cancer. So I expect that if as a woman you know that you have a period every month and then you start bleeding maybe during your ovulation or you're bleeding outside of that monthly cycle, it's not normal. If you're bleeding after exercise, it's not normal either. So you need to see your doctor. The doctor will ask you more questions, perform a pelvic exam, and test for infection, including STIs. You might get a scan and you might be referred to a gynecologist if we don't find out what's going on. And postcoital bleeding means bleeding that occurs during or after sex. Now, we are kind of all aware, we're aware that if a virgin, let's say she gets married, has sexual intercourse, she might bleed. I'm not talking about that bleeding. I'm saying if every time you have sex, you're experiencing blood, you're seeing blood after, that's not normal. Okay. So again, in some cases it can happen. So that's idiopathic. We don't find the cause, or it could be an infection. So that's why you need to see your doctor so they can do a pelvic exam and even take some swabs. If you have been having sex, premarital sex, or sex outside of marriage, or sex with multiple partners, again, you might have an STI. So you need to see the doctor about that. It could be PID, it could be cervical ectropion, it could be a polyp, or it could be cancer. So again, the doctor will ask questions, perform a pelvic exam, test for infection, which could include swabs and even a blood test, and refer you for a scan. And if we still don't find anything, then refer for a gynecologist. So looking at the comments, I saw somebody say that they always thought that a cervical smear was for people that were having sex. So I want to just, that's not true, even though it's something that a lot of people assume that it is. So they just ignore that letter. So I want to just give you some scenarios. Just imagine there's this woman who is very religious, whatever religion she is, she knows that she's not supposed to have premarital sex. So she doesn't have sex. And then she turns 40, or she's in her 40s now, has never had sex before until the wedding night. The wedding night comes and it's just so painful, and she's bleeding everywhere. They try again, very painful, there's blood everywhere. So she goes to the doctor. Doctor examines her and sees a very massive polyp on the cervix. That's not cancer, but it's something that can be easily treated. And the doctor asks, how long have you had this thing? It's so big. Oh, she has no idea, because she's never, obviously, it was the first time that she had sex, and she's never attended her smear appointments. Then they have to send her to the gynecologist to have it removed. And there's such a delay now. She's supposed to be enjoying her marriage on a honeymoon, but because she has neglected to go to the doctor to have this, to have somebody have a look at her cervix, because she was so worried, or she was told that because she was a virgin, there was no need to have a smear. So that's one scenario. Okay. Another scenario is those women who tell you that they're virgins, but actually what they mean is that they've never had penetrative sex, but they've been indulging in oral sex and other types of sexual things. HPV, which is the virus that we also test for when you have your smear, can be passed on via oral sex, not just penetrative sex. So those kind of women, they will tell you, oh, they're virgins, blah blah blah, but they're still at a high risk of cervical cancer. So these are the reasons why it's so important, no matter if you're sexually active or not. I think, again, if you're truly a virgin, never had any kind of sex, I think it's still important that somebody has a look, even if it's just a look. When you go for that appointment, and I put this on this slide, what to expect. When you go, somebody's asking you questions. You might have never gone to the doctor for any issues, and you might not even know what's normal or what's abnormal. But at this appointment, you have a healthcare professional asking you questions that's making you think, oh, actually, I've been going through this and I didn't know it was not normal. So it's a good idea to go. Now, if you go, for example, and you just couldn't tolerate it, then we know that there's something going on that we can hopefully help the next time. We can try to make you more comfortable. We can give you a double appointment next time. We can just try, and because a lot of times all you need is just to be relaxed. If you're more relaxed, then you can tolerate the examination. But please, I just want to encourage women that it's okay to go for your smears. We have different sizes of speculums. So there's the very small size that will not break your hymen if you're a virgin. It's just important that somebody has a look at your cervix, and that we take swabs to check for HPV. In the UK, women will be invited when they turn 25, and then it will be every 3 years until they turn 49, and then it'll be every 5 years. Okay. And why do we do it? Is to check the health of your cervix. So it's not just to check for cancer, it's just to check, is your cervix healthy? If we find something, can we just treat it before it gets worse? Okay. And it takes a sample to check for HPV. So every woman that gets an appointment, gets a letter, should really go. Don't ignore it. It's so important. Okay. And if you're pregnant, they usually would delay the smear until 3 months after you've had your baby. Okay. So I think I've mentioned what to expect. Okay. And you usually will get your results about 3 to 4 weeks later. If you find that you get a letter and it's saying you're HPV positive, don't be too scared. Okay. Usually what happens is they'll ask you to come back in 1 year for instead of 3 years for a smear. If it's still there, then they usually will do a referral. If they find abnormal cells, they will refer you for colposcopy, which is basically where you get like a specialist looking at your cervix with like a magnifying glass or something to have a better look at your cervix. So please, it's so important that women understand the importance of having their cervical smears and that you attend the appointment. Okay. So I want to summarize. When do you see your GP? So if your menstrual cycle doesn't start by 16, you need to see your GP. If your cycle is infrequent or irregular, you need to see your GP. If your periods are painful, if your periods are heavy, if you experience vaginal bleeding outside of your monthly cycle, if you experience bleeding after sex, and if your periods stop for no obvious reason. Okay. So we're going to talk now about contraception. So Kathy, she's 35 and has 4 children. Her youngest is 6 months. She's feeling very overwhelmed with motherhood and wants to discuss contraception. I'm sure there's so many of us who might be in this phase of life as well. I only have 2 children, but on some days I get really overwhelmed with motherhood. So what kind of contraception is available and what is suitable for you? So I want you to think about these things when you're considering contraception. Think about your age. Think, because there's some contraceptive methods that are not really suitable for women who are above sort of 40, for example. The combined pill, you can still take it, but however, the risks of things like blood clots, breast cancer start to increase over the age of 40. Think about your medical history. Some women have migraines. You can't have the combined pill if you have migraines. If you're obese, if you're above a certain BMI, you can't have it. If you're epileptic and you have medications, there's some contraceptives that you cannot take. Also think about the practicality. Do you really, are you at a phase of your life where you can really be remembering to take a tablet every day? Or are you in a phase where you can remember to use condoms? You know, you have to think about the practicality. Think about the duration. Now, is it long term? What are you thinking? How long do you want to have something that you can stop easily so you can have your baby? You know, just think about the duration that you want. Are you breastfeeding? Just think about those kind of things. Think about the long term effects. There's the one contraceptive, which is the contraceptive injection. It takes 12 months after you stop it for your fertility to return. So you need to think about it. That's 12 months of, you know, so if you want a baby quickly after you stop contraception, that's probably not the one for you. Think about the reversibility. So do you want something that's reversible or something that's more permanent? If you're thinking more permanent, then you might be thinking of your husband having a vasectomy or you having sterilization. Do you want something that's hormonal or something that has no hormones? So these are things to just think about. And sometimes you might just have to have an appointment with your nurse or your doctor to talk about these, to weigh up all the different things that you're considering to help you make that decision. And on this slide, I want to talk about how effective is it, the methods. So some of you, you're married and everything, but you're still using condoms. Think about it. Are you actually, are you remembering to use it? You know, sometimes they split. So again, I'm starting on this slide. I'm starting at the bottom. These are the least effective methods. There's a female condom. There's a diaphragm. Are these very effective? There's some women just look at the calendar and they avoid the months that they're the times that they're ovulating. It's not very. It's not very effective. Some are using the pull-out withdrawal method. Again, it's not very effective. However, it's always your choice. So just think about these things. And then in the middle row, we're looking at the ones that are a bit more, more effective. Again, it all depends on if you're using it perfectly, because I mean, how many people can say that they are really using their contraceptives perfectly? The pill, sometimes you forget to take it. But let's talk about the pill and the other method. So you have the combined, it's only sort of the type that is combined has two hormones in it, estrogen and progesterone. It comes in a pill form, it comes in a vaginal ring, it also comes in a patch. Okay, I know the one that's the most common is the pill. So with that one, you get a packet. Usually we prescribe 3 months each time, and once you get used to it, we can prescribe you for 6 months or 1 year, and you need to take it. But if you forget to take it, then again the risk of pregnancy is high. That combined pill is what we also use sometimes to help women with their painful periods or with their heavy periods. And then you have the progesterone methods. This is the one that only contains progesterone. We find that it can be safer. So the risks of things like breast cancer can be lower with the progesterone only methods. It comes in a pill form. Again, this is the pill that you take every day without a break. It comes in an injection form. With the injection, you're having to go to the doctors every 3 months. So you have to think about it. Can I actually make it in time to the doctor every 3 months to have an injection? Another one is the implant, the contraceptive implant, which can stay for 3 years. And this has to be fitted by a doctor or a healthcare professional. So they need to be trained to do it. And that's another option. But again, if you think about it, if something were to go wrong and you don't like the way it is, you have to go back so that they can remove it early. And then you have the coils and you have the hormonal coil. Like I mentioned before, the brand that we commonly use is the Marina coil, and it helps to reduce your heavy bleeding, and it is also good as a contraceptive. Now, the thing about the coil is there, and you just leave it for 5 years, so you don't have to keep going back to get it. Another thing about the coil, recently, I think in the past 6 months, I would say, or more, it has now been licensed for 8 years. So it used to be 5 years. Now it's 8 years for contraception alone. If you're using it for heavy bleeding, then it's still 5 years. And if you're using it for HRT, it's only 5 years. And then you have the copper. The copper coil does not have any hormone. It's just copper. Some of the things I tell my patients is that it can cause your periods to become a bit heavier and more painful. But again, it doesn't happen to everyone. And then with that one, it's good for women that don't like hormones. Some women are very sensitive to hormones, so they prefer to have the copper coil. And you have the brands that are licensed for 5 years, and some you can leave for 10 years. So you need to know which one that your doctor has inserted. Is it the 5-year one, which means that you have to go back in 5 years to have it replaced, or the 10-year one, which means you can wait 10 years. And then you have the more permanent methods. On the NHS, even though some people will tell you that it's reversible, vasectomies are not reversible on the NHS. If you're paying for it, you might find a doctor who would actually be able to reverse it for you. And then you have sterilization, which is also not non-reversible on the NHS. Okay. So these are things to consider when you are choosing contraception. And I can't talk about menstrual issues without talking about vaginal discharge and what is normal. So what is normal vaginal discharge? It should be about white or clear. Now the consistency, so how, the thickness, the way it feels can change throughout the menstrual cycle. It can also change during pregnancy. So just be aware of this, okay? And then if, for example, you notice that you're now having very white discharge, but it's very clumpy, that could be candida, a yeast infection, which we commonly call thrush. Okay, some of the symptoms include itching, itching around the vulval area, and this thick white cottage cheese discharge. Okay, there's another one called bacterial vaginosis, which is a bacteria that can happen. Again, it's not only transmitted via sex, it can just happen to women because of the pH of the vaginal fluid. Okay, the symptom is usually very offensive discharge that can be off-white or gray in color. Some women have no symptoms, so they don't even know that they have it until they come in for something else. We do a swab and we find it. But some women can just tell that something has changed. It just smells different. So this is the most common cause of abnormal discharge in women of reproductive age. And then you have discharge that's caused by STIs, chlamydia or gonorrhea. Again, some women have no symptoms, but if you're having sex that's not safe, then you're at risk of this. It could be yellowish green discharge, and usually the woman will experience some pelvic pain as well. They might feel very unwell. They might experience postcoital bleeding. If you have any of these symptoms, then please, you need to seek help. Now, on that picture, you can see some red discharge as well. During your period, yes, you might experience that. But if you notice that even when you're not on your period, you're having red vaginal discharge, again, that's not normal, and you need to seek advice from your doctor. Okay. And this is just a slide about vaginal care and how to look after yourself. Okay. So again, if you choose to have premarital sex or sex outside of marriage or with multiple partners, please use a condom. Please, it's not just enough to get contraception. You need something to a barrier to protect yourself. And then please wash the area, daily. Also avoid products that will irritate your vagina. You can use water, it's fine, or you can use the emollient soap substitutes. Okay, avoid douching. I'm not going to talk too much about that. If you don't know what it is, then it likely means that you're not doing it. Okay, so if you use tampons, change them regularly. I had a woman that came to see me. She had vaginal discharge that was that was horrible, and when I examined her, there was a tampon there that she had left for only God knows how long. So if you're going to do these things, let's look after our health. Okay, take them out, change them regularly, don't just forget it there. And wear breathable underwear. Okay, and change your underwear daily as well. And then just again to summarize vaginal discharge, if you notice symptoms of genital thrush, because you now have the information, you don't need to go to your doctor unless you're pregnant or breastfeeding. You can just go to the pharmacy and buy clotrimazole, vaginal pessary, and cream. Okay, it's usually quite safe. It's not a tablet. They do have tablets, but usually your pharmacist can ask you questions and then they can treat you. But if you're pregnant or breastfeeding, then don't use any medicine without speaking to your doctor. Women that have recurrent thrush, so let's assume that you keep having thrush, you keep having bacterial vaginosis, see your GP, okay? Because they will need to do some swabs to confirm the diagnosis, and they can give you medication like a weekly antifungal treatment to help prevent it from happening. And if you have any symptoms of STIs, you can always go to the sexual health clinic. Most hospitals will have a sexual health clinic within the community that you can just go, walk-in center, without going to your GP. But also, you can feel free to make an appointment with your GP as well. Okay, so I've done a run through menstrual disorders. Okay, and it's nice to see that people can relate, and there are some things people have shared that they've gone through some of those things. So I hope that if you have questions, just keep your questions. You can even type them in the chat, but I'll be doing a Q&A at the end of the talk. We're going to move on to a more sensitive topic, and this is infertility. And I just want to any woman who has gone through this or even might be going through this right now, I think I just want to, empower you with information and just know that you're not alone. And I'm going to share quickly a bit of my story. So I got married almost 9 years ago. And when we got married, my husband and I wanted to just take sort of a year to just enjoy ourselves and things. And I think I mentioned earlier that I used to have period pain, but I didn't really talk about how I got through it. So I used to use painkillers. And again, at some point when I got to medical school, the painkillers were just not doing enough. So I was still missing a lot of school. And one day I spoke to my tutor, who suggested that I go back to my doctor and go on the pill, on the contraceptive pill. So I did that for some years, and it helped. But I just knew that I was going to be getting married, and I wanted to stop any pill, any contraceptive. So I stopped everything, and my periods, they came back, but they were not too bad. I could cope with the pain at that point. So anyway, 9 months after I got married, I became pregnant. At that time, I was not a fully qualified GP yet. I was doing my training, and I was training in obstetrics and gynecology. So I was working in the hospital, and I was on call that day. So I was supposed to assist another doctor in a cesarean section in the theater. And over the weekend, I found out I was pregnant. This was Monday. I was experiencing pain throughout the weekend, but I just thought it was just pain, nothing to worry about. And until I had the most severe pain on my left side, my left pelvis area, and I went to the obstetrics ward. So I spoke to the midwife, who saw that I was in so much pain. I was crying. So she got the consultant in, and they asked me to lie down. They got me a scan, and she told me, "I'm really sorry. I can't see anything inside your womb, but I can see something in your fallopian tube, and they think it's an ectopic pregnancy." Um, so again, I was like, "Oh my goodness!" Obviously, I knew about ectopic pregnancies. So they said I had to have surgery that same day. So they rushed me to theater, and they had to take out my fallopian tube. So it was a horrible experience, but again, thank God I was in the right place for everything to sort of go smoothly. And then 3 months later, I got pregnant again. And usually, when you've had a pregnancy loss, at least in most areas in the UK, you can have an early scan. So I got an early scan, and again, they were telling me they couldn't see any. They could see a sac in the womb, but they couldn't see any sign of life. So they kept asking me to come back for scans. Eventually, I started bleeding, so I knew that that was a miscarriage. But I just want to thank God that after that experience, got pregnant again, and now God has blessed me with my two children. I have a 6-year-old and a 4-year-old. So I just want to just let women who might be going through this or who might have already gone through this, that there's nothing that God cannot do. And also, I want you to be aware of the signs, so that you know what's happening if anything like that happens to you. So let's talk about Nikki. So Nikki is 38. She's been trying to conceive for 5 years. She's always had infrequent periods, and she was put on the pill in her 20s, which helped manage her periods. Now, she stopped the pill 5 years ago when she was wanting to try for a baby. So 5 years have gone by. Nikki has still not been able to conceive. Okay. So already, I'm thinking, oh gosh, there's so many different causes, which we're going to go into shortly. So what is infertility? It's the failure to achieve a pregnancy after 12 months or more of regular unprotected sexual intercourse. And you have primary and secondary infertility. So primary is the one where the couple have just never conceived. So the man hasn't, and the man hasn't been able to get a woman pregnant, and the woman herself has never been pregnant. And then you have secondary infertility, where the couples have maybe they've conceived at least once before. So they might have been pregnant and now have a child, and they just not been able to do it again. And then subfertility indicates a delay in conceiving. So which means pregnancy will still occur, but it's taking longer than average to happen. So let's talk about the causes. Now, this is sort of a talk for women's health. So I'm not going to spend too much time talking about the causes of infertility in men. It's mostly about women. And a few causes. Okay, so 25% of couples who are going through infertility is that the woman has ovulatory disorders such as PCOS, thyroid disorders, endocrine disorders, uncontrolled diabetes, or end-stage kidney disease. And again, this list is not exhaustive. And then 20% of the couples who are experiencing this could have tubal damage caused by pelvic inflammatory disease or STIs, where the fallopian tubes are blocked. Okay. And then 10% of the couples who are going through infertility, the woman has uterine abnormalities like fibroids or endometriosis. And in 25% of these couples, it's unexplained. We don't find out medically, we don't know why it's happening. And 30% of couples who struggle to conceive, it's actually there's a male factor that's causing it. So maybe low sperm count, or the sperm is not moving properly, motility issues. So it's very important that couples seek help together. It's not just the woman's, it's not just the woman's issue. You should seek help together. It's not just the woman's responsibility. The man should also go and see his doctor, ask for a semen analysis or something, so we can find out what the cause is. Let's talk about the factors. What can contribute to infertility? Being older, we do know that fertility, especially for women, there's an age where you get to that your ovaries are not producing as much estrogen. So again, older age. Obesity, being overweight, can also increase that risk. Low body weight. So earlier we mentioned that weight loss, can contribute to having infrequent periods or no periods at all. So that's why that can impact fertility. Some medications, okay, oral steroids, for example, long-term use can cause that. Then smoking, excessive alcohol, sexually transmitted infections, stress. These are some factors that can contribute to infertility. I'm going to be talking now about two conditions which are quite common and which I just want us to be aware about that can lead to infertility. And one is endometriosis. So I'm sure people would have heard about endometriosis. There's so much sort of research being done and awareness is being made about endometriosis. It's a disease in which the tissue that's similar to the lining of the uterus grows outside the uterus, and it can grow in the fallopian tubes, the ovary, the bowels, the bladder. Okay, and what this means is that every time that tissue is bleeding, that monthly cycle, it's also bleeding in the bladder, it's bleeding in the bowels, wherever it is, it's bleeding. So that woman is in so much pain, has painful periods, pain during sex, pain that might be also related to sort of bowel type pain. Some of them will have pain when they're passing urine and even bleeding, so blood in the urine. And there's another condition that I'm seeing a bit more of called adenomyosis. And it's a condition where the lining of the uterus, the endometrium, grows inside the muscle of the uterus. So again, they're in so much pain. Sometimes they're having period pain and also pain in the pelvis all the time and heavy bleeding. So I wanted to highlight these two conditions. And I'm not going to go into so much detail when it comes to the treatment. Endometriosis is a very difficult diagnosis for doctors to make. Even gynecologists struggle sometimes. But when I see women with these symptoms, I send them for blood tests, a scan. Ultrasound scans are very unlikely to pick up endometriosis. So if your doctor tells you, oh, your scan is normal, it doesn't mean that you don't have endometriosis. It's a good idea to push your GP to refer you to a gynecologist. The way that we diagnose endometriosis is by doing a laparoscopy. So where the gynecologists look using a camera, so it's like a keyhole kind of surgery, and then they look into the pelvis, they look into all the areas to see if they can see the endometrial tissue in the pelvis. Okay. Now, because again, it's surgery, the gynecologists don't want to perform surgery on every woman who's experiencing this. So sometimes, if you can cope with the pain, or if your GP gives you contraception, like contraceptive pill or the Mirena coil, if your symptoms are better, the gynecologist might decide not to do that laparoscopy. Okay, they will just say something like, we think you have endometriosis, but let's give you these treatments instead of going down the route of laparoscopy. But MRI scans can sometimes pick up endometriosis as well. Okay. And then PCOS, which is the most common cause of infertility in young women. And the main things that women will experience with this is that ovulation disorder, where they might have very irregular periods or infrequent periods, or they might not have periods at all. So that's one of the reasons why these women will come to the doctor and say, oh, something is wrong with them. They usually, on their blood test, they have excessive male hormones. Okay. And then some of them will start to notice facial hair or just excessive hair growth. And some might have acne. And then when we do a scan, we see that they have cysts, multiple cysts on their ovaries. So the treatment, again, a GP can handle this. You don't have to be referred to a gynecologist. However, I need to know, have you sort of finished having your children? Because women with PCOS can have children, like normal. Not all of them struggle with conceiving, but some of them do. So a woman who is not ready to conceive, so I see some young ones that come early because they have irregular periods, and we do the scan, blood test, and we say, oh, it's PCOS, but you don't need to do anything yet because you're not at that stage where you need to have, where you want to have a child. So if you're overweight, I'll encourage that you lose weight. If you have acne, excessive hair growth, I will give you treatment for that. I will try hormonal contraceptives to help manage their periods and monitor their blood pressure, because with PCOS, there's a risk. It increases the risk of developing things like high blood pressure and diabetes in the future. So these are some of the things that I would suggest. And then women who are trying to conceive, with these kind of women, I don't like to waste time. I prefer to just refer them, because again, that's, they're at that point where there's a higher risk of infertility. So I don't want to waste any time. I like to refer them quickly, but encourage them to, get to a healthy weight and monitor their blood pressure, do blood tests to check for diabetes and other things, and then I just refer them. Okay. Now, again, when it comes to infertility, I'm not a fertility expert, so I'm not going to go into all the different treatments available. I just have to mention that in the UK, they have the NHS fertility clinics have a very strict guideline and criteria. So a lot of times I just refer, because the guideline keeps changing and they're the ones who know what the criteria is. So I refer, but sometimes I receive a letter saying, oh, this patient is not eligible for NHS, fertility treatment. And unfortunately, that means that the woman and her husband, they have to pay. So just be aware of this, okay? That even if you're, even the white British don't always meet the criteria. So obviously it's worth getting referred, have the referral, let your GP refer you. And then it all depends on, if you receive a letter saying you're not, usually they'll explain why you're not eligible for it, which means that you might have to go private if you want to get fertility treatment. Okay. So let's talk about Pam. Pam is 32. She's 10 weeks pregnant, very excited to have a scan in 2 weeks' time. But while she's at work, she starts to experience abdominal pain and vaginal bleeding. So we're going to talk about early pregnancy loss. And I just want to highlight the things that you just need to watch out for, the things that you need to know. So miscarriage is the spontaneous loss of pregnancy before the fetus reaches viability. So usually early miscarriages are sort of less than 13 weeks, and then late miscarriage is sort of 13 to 24. Okay. And it's so common. When I experienced pregnancy loss, I didn't know, it wasn't talked about so much. I didn't know, I thought I was alone, and I was just trying to find out who else is going through this. I think with social media, and there's a lot of awareness now. People, you see people who say it online, but again, not that many. So I just want to highlight how common it is. 1 in 4 women, so 25%, will experience a miscarriage in their lifetime. So know that it's not your fault. Sometimes it happens and we don't find out why, so just want to make you aware of that. So some of the symptoms include pelvic or abdominal pain in a woman who has missed her period. So again, somebody who's pregnant, vaginal bleeding, and in some cases, the woman doesn't even know she's had a miscarriage. It's when she turns up for that scan. And I've been in that position where I was the doctor observing, and the woman is so happy, comes with her husband, and the moment they put the scan on, we don't hear a heartbeat. And it's so sad. She's in tears. They can't believe it. And unfortunately, we then have to induce her so that she can either, pass it, or if passes naturally. So it's always a very painful time for anybody who goes through this. Now, I want to mention, if, for example, you've had 3 or more miscarriages, and some women have miscarriages at home, so they never go to the doctor. If you've had 3 or more, you should go to your GP to be referred to a specialist for investigation, because we need to find out, why is it happening? Why did it happen 3 times? Yes, sometimes some women will experience it once or twice, but 3 times we need to find out, maybe something is wrong. And then an ectopic pregnancy, like I mentioned, is a pregnancy that occurs outside the uterus. Now, the symptoms are pelvic or abdominal pain in a woman who has missed her period, so one who is pregnant. Vaginal bleeding does not always occur. So sometimes a woman might not even know what's going on. She just knows that she's in pain. Some women feel faint and dizzy. Now, ectopic pregnancies can be life-threatening, which means that if there's a pregnancy outside the uterus, which is never going to survive, we know that, but it can rupture, which means it can burst, and the woman can start to bleed internally. So that is why it's important that you know the signs. If you're pregnant, any kind of pain that you have that is just is too severe for it to just be normal pregnancy pain, always seek urgent help. Okay. So, just some tips for women who are trying to conceive. Always track your cycle and optimize your ovulation period. We always say at least have sexual intercourse with your husband at least 3 times a week. Take prenatal vitamins. If you have experienced an early pregnancy loss, even if it's just once, you are entitled to have an early scan in your future pregnancies. Most hospitals in the UK should have an early pregnancy assessment unit. And if you have the number, you can just call them yourself. So you can go online, check your hospital, check the area where you live, and search for EPAU. If you don't find anything, you can contact your GP, and then they can refer you. It's a good idea, and it gives you some comfort knowing that you don't have to wait 12 weeks for that scan, that you can get an early one around 6 or actually around 7 weeks, just to make sure, to give you reassurance that you can know that your pregnancy is okay, because it comes with anxiety when you've lost pregnancies in the past. There's so much anxiety, and I think this gives you sort of some reassurance, and that helps. And if you've had a pregnancy loss at any stage and you're struggling with your mental health, and I know that my slides and this conversation might have triggered some emotions in some women, just know that you can talk to somebody about it. You don't have to bottle it in. It gets, I want to say that again, like my story, it's ended in a testimony, and I just want to let you know that you're not alone. Don't bottle your emotions in. It's good to I journaled a lot during that time, and sometimes I would look back at my journals and I'm like, God, thank you, Jesus for giving me my children. So don't bottle it in, and just know that you're not alone. Okay, so I'm just going to take a water break before we move on to our next talk, which is the next section, which is the last section. Okay, so we're talking about perimenopause and menopause. And again, I quite like the scenarios where you can hopefully see yourself in some of the examples I've given, or see your auntie or sister or cousin in that example. And this is Tammy. So Tammy is 42, and she's noticed a change in her menstrual cycle. Her periods are heavier and irregular. She's not sleeping well at night, and she's experiencing palpitations. And she's noticed that she feels bloated after eating certain foods. So I wanted to put this scenario in because you might think, oh, 42 is quite young, but I'm seeing a lot of women come to me, and most of the time, the first thing that they complain about is they've noticed a change. So this is, again, talking about being aware of your body, knowing what's normal for you, and knowing when there's a change in your menstrual cycle. And she's also not sleeping well at night, and she's experiencing palpitation. Now, for the doctors and nurses among us, it comes with experience for you to start thinking that could this be perimenopause. Because I remember earlier in my medical career, I would see this and I would just say, well, it could be fibroids, and then I'm thinking she has palpitations, or she has maybe she has a thyroid disorder. I would separate, I would tackle each symptom separately. I'm like, oh, she has IBS, everything is. But then now, with more experience, I'm able to ask the right questions. And a lot of times I'm like, actually, it's the hormones. It's not separate things. Don't get me wrong, sometimes they are separate things, but that's where, as a doctor, as a medical professional, you need to sort of ask the right questions so you can get to know, is this hormonal, or is this something else? And now, because there's so much awareness now about menopause and perimenopause, I actually have women now who come and say, I think it's hormonal. So they've already done their work. They've kept a diary, and they're like, actually, I get headaches at this time of the month. So I think this headache is hormonal. So it's really good to, I think the one key thing I will say that everybody takes away today is know your body, and always think, ask yourself questions. Is there a pattern to this thing that I'm experiencing? And then when you go to your doctor, because as those of you that live in the UK know that the GP only gets 10 or 15 minutes with the patient. So you need to come prepared as well as a patient, if you really want to get a good solution and plan from your doctor. So she's noticed a change in her cycle. So again, in my head, I'm thinking, okay, I'm going to get some blood, examine her, ask her some more questions, find out what's going on with her. And it could be perimenopause in Tammy's case, even though she's 42. And then I have another scenario here. Love is 56. She's been married for 30 years, but she's become forgetful. She's had 3 UTIs in the past 3 months. Sex is painful, low libido. So she sees a doctor. Okay. So let's talk about perimenopause and menopause. So perimenopause is the stage before menopause, and women can start to develop menopausal symptoms and even changes to their menstrual cycle. Some women experience this quite early. Let's say a woman has had large ovarian cysts or even ovarian cancer at a young age. If she has surgery to remove the ovaries, then she's going to automatically be pushed into menopause. Menopause is a normal stage. Okay, it's not a sickness, it's not a disease. Every woman is going to experience it sometime. And it's a stage in a woman's life when her periods will stop because the ovaries will stop functioning. And we can diagnose it clinically without even blood tests if a woman is over 45 and her periods have stopped for 12 months. Okay, early menopause is when the ovaries don't function well, and that can occur between 40 and 45. So the woman might just notice between 40 and 45 that her periods are just either all over the place or they become lighter. And then premature menopause is when all this happens before the age of 40. So again, know your body. If you're over 45, your period stopped for 12 months, then you might be thinking, I think I think this is menopause. But if you're not sure, see your doctor. But if it's happening before 45, just go and see your doctor. So symptoms of menopause, again, so many different symptoms. And, I'm getting better, with more experience at picking out which ones I need to, treat separately. But some women will have only 1 or 2, some women will have a lot of these symptoms. So it's all about, finding a doctor who understands what you're going through. We still have doctors in medical school. I didn't get much teaching about menopause. It was because of my interest in women's health. I had to do a lot more studying, a lot more courses, and with more experience now, I'm doing this. And I have women that will go now practice website, and they will see, because under my name it says women's health specialist, and they choose to see me because they want they want a doctor who has knowledge in that area. So if you find that you've been to a doctor already, you're not satisfied with what you got, it's worth asking your practice, is there a doctor, a GP who actually has an interest in this area, so that you get the right treatment. Okay, so during menopause, the levels of estrogen and progesterone falls, reduces. And again, there's some impacts on menopause, which I will talk about later. But like I mentioned, if you're over 45, just look at those symptoms, take a screenshot if you need to. Your GP can diagnose this without blood tests. However, if you're over 45 and you haven't had a blood test in a while, it might be a good time then to just ask your doctor to check for cholesterol, check for diabetes, check for different things, just so that you're getting your health check. And if you're under 45, and you're experiencing these symptoms, just know that you'll require blood tests to check your hormone levels. Okay. Sometimes the hormone levels come back normal. So just bear that in mind. It doesn't mean that you're still not perimenopausal. We can make the diagnosis based on all your symptoms. So the effect of menopause on the body, it can reduce strength and density of bone, so that's osteoporosis. Okay, it can increase the risk of heart disease. It can cause weight gain, changes in mood, can affect the way the bowels work. It can lead to low libido. It can cause genitourinary symptoms like vaginal dryness, increased frequency of urination and urgency, even sleep. It can affect your sleep. It can affect the skin. I mean, who knew that it's just lacking estrogen and progesterone can cause all these things? But this is why, even though menopause is not a sickness, this is why some women are just coming to the doctors like, I need help because they're struggling with the symptoms. Okay, I'm always asking like my mom, aunties, like, how did you guys do it? You know, because some women just push through, but we're just trying to make you aware that there are things that you can do that to help yourself. Okay, you don't always have to go on medication, but I want to talk about the medication that is available also. So HRT is hormone replacement therapy, and it's treatment for women who are struggling with menopausal symptoms. Now, not every woman can take HRT. So there are women who've had breast cancer before who cannot take HRT. So you always need to speak to your doctor or menopause specialist. Now, the type that you need depends on your symptoms and your medical history and your preference. Okay, so there are types of HRT. Some include estrogen only. So if a woman has had a hysterectomy, she only needs estrogen. If she has a uterus, like many of us do, then she needs a combined HRT. Now, it comes in different forms: tablet form, gel, patch, spray. The doctor will discuss all that with you. Now, testosterone in some areas, I mean, I've just recently started prescribing testosterone. Not going to go too much into that, but testosterone is another hormone that's lacking when you're going through menopause, and it can help with low libido. Okay, and then vaginal estrogen. Now, for women, some women just have vaginal dryness. They find it's so painful to, doing intercourse. And again, there's so many other causes of painful, pain during sexual intercourse. So your GP just needs to ask questions, examine you, and find out, is this menopause or is this something else? And if it is down to menopause, then vaginal estrogen can be prescribed. So I want to encourage women to just live healthy, no matter what age you are. We're all going to experience menopause at some point. So why not start now, with just taking care and charge of our health, making sure you're exercising during the menopause and perimenopause. Women start to lose muscle mass. So it's really important that you're, exercising, doing strength training, lifting weights, doing squats, just to build your muscles. That would definitely help in the longer run. Nutrition, making sure that you're cutting down on carbohydrates and saturated and unsaturated fats, or saturated fats rather. And then making sure you're drinking plenty of water, keeping hydrated. In this country where we don't get much sunlight, during the winter months, it's so important to get vitamin D supplements or to take it, and also calcium supplements as well, just to help with the bones. I mentioned the lack of estrogen can lead to osteoporosis, so try and prevent that. And at any age, it's okay. We're advised that during the winter months especially, it's good to take a vitamin D supplement. Okay, now I haven't gone into the different supplements, and I find that when it comes to menopause, there's so much in the market. People are just trying to make money. The British Menopause Society does not recommend any one supplement, so you need to do your own research. I will speak to a pharmacist or a nutritionist about what supplements to take. The one that's recommended is calcium and vitamin D. Okay, check your blood pressure regularly. If you have if you're at high risk of diabetes or high blood pressure, then have your annual blood tests. Sleep well. Don't smoke. Don't drink alcohol excessively. Make sure that you're taking time to refresh. As moms, as women, we're just always looking after everybody, but it's time to we need to take care of ourselves as well. Okay. And I already mentioned the cervical smears. In the UK, you also get mammograms when you turn 50, and it happens every 3 years until 71. And even you don't have to wait until 50. Be checking your breasts, every month. If you notice a lump, then make sure you go to the doctor. And I say it again, if your period stopped for 12 months, if you're over 45 because of menopause and you start bleeding again, that's not a period. It could be endometrial cancer. So please seek advice. And I want to make us aware of sort of the common cancers that can affect women. Just want to give or just shine a light on the kind of symptoms that should make you think that I need to see my doctor. And, the one I mentioned earlier, and I'm going to mention again, if there's unexplained vaginal bleeding more than 12 months after menstruation has stopped because of menopause, then It could be endometrial cancer. Don't ignore it. Any changes in bleeding pattern that's also associated with pelvic pain, weight loss, anemia, see your doctor. Symptoms of bloating, just feeling full very quickly, lots of appetite, pelvic pain, increased frequency of urination, weight loss, changing your bowel habit at any age, really. See your doctor. Could be ovarian cancer. And then symptoms of vaginal or vulval lump for more than 3 weeks, any ulcer in the vulva, any bleeding on the vulva, from the vulva, could be vulval or vaginal cancer. And breast lumps, doesn't matter how old you are, always see a doctor. At least they will get you a scan so we can check if it could be a cyst, a breast cyst, it could be a fibroadenoma, but we want to make sure it's not cancer. Okay. And for anybody who's still listening to me, thank you so much for listening. Thank you for your time. Thank you for just coming here to gain more knowledge. I appreciate all of you. We're going to move on to the questions and answers. Thank you.
All right. Thank you so much, Dr. Anu. He really enjoyed that session. Please, can you put it in the comment section? Let's shower her with the fire emoji if you really enjoyed the session. Don't pretend, right? I don't want you to, yeah, just tell her how much you enjoyed the session. It was really mind blowing, and it was also very, it's an eye-opening session because you said some things. I'm like, oh really, so this is what is causing this. I'm like, oh, okay, I need to check with my doctor. So thank you so much for today's session. Thank you. You can see the comments. See, everyone is saying thank you, Dr. Anu, for thank you for an educative and informative session. Thank you, very insightful. Thank you. There are some things that we assume are, I mean, normal now. It's normal. That's one of the packages that come with being a woman. And now you have demystified that no, not everything is normal. You still need to go for a checkup if necessary. So please, if you have any question, please go ahead and put in the comment section. Please go ahead. I think the question there, you have answered it. How often should one do cervical smear? I think you have answered that already, yes. And yeah, if I'm correct.
Yes. So every in the UK anyway, it's every 3 years from 25 up to 49, and then every 5 years from 50.
Yeah.
Um, yeah. But if you're not in the UK, again, we're blessed here that we get an appointment, we get a letter that helps remind us. But I
That's
know in some other countries, again, like in Nigeria, you might have to
ask for
you
it.
have to go and meet your doctor and ask for it. Yes.
Okay, I have a question here, Dr. Anu. Please, after 2 kids, can one still develop PCOS? That's polycystic
Yeah,
ovarian
polycystic
syndrome.
ovarian syndrome. So
Yeah.
the thing about that is some people already have it, okay, and they either have no symptoms, because it just means they cysts on their ovaries, and some they have excessive male hormones, but maybe it's not excessive enough to manifest, okay, to manifest in with the facial hair and things like that. So some of them can still go on to have children. Now, in some other cases, I've seen women who already have children and then develop it. However, like I've mentioned, any change in your period, any change in your menstrual cycle should raise alarm bells. But it's more likely that a woman already has it, but the symptoms or the level of hormones that the male hormones are not at a level where she then has symptoms, and it could present itself after she's already had children.
Mhm. All right, thank you. Any other question for Dr. Anu? See, we still have enough time. Please feel free posting your question. And if you would like to connect with Dr. Anu after this event, I'm going to share our Instagram page. If you are in the PSP community, I can bet you have a direct access to her. So just, I'm going to tag her. So you just chat her up. But if you're not and you don't want to join our community, you can actually reach her on Instagram. That's her Instagram handle if you'd like to connect with her. I think I have to comment. Okay, Doctor, and someone is asking, what is the health implication of vaginal polyps?
Okay, so I'm not sure if you mean more cervical polyps.
Cervical polyps, I think.
So cervical polyps. So the implication of that is some women, we don't even do anything about it because it's not causing them any problems. But when it gets to a point where it can be quite large, then it can cause pain, especially during intercourse, or bleeding as well. It can also cause intermenstrual bleeding, so bleeding outside of their menstrual cycle. Now, there's also endometrial polyps, so polyps that occur inside the womb. And a lot of times women have it, but we haven't picked it up until they come to us and say that they are bleeding outside of their menstrual period. So the implication, again, it doesn't, it's not one of those things that usually develops into cancer. So I would say in some cases, you don't have to do anything about it. It's just that if it's quite a large polyp, then as you can imagine, it can start to bleed and it can start to cause you pain, especially during intercourse. So that would be the implication: pain and bleeding outside of your menstrual cycle.
Thank you, doctor. So I have another one. If you are on Mirena coil for 6 years and not seeing your period, should you be concerned? And if you see occasional light bleed, should you see a GP?
That's a very good question. So I think I mentioned earlier the Marina coil was initially licensed for 5 years. Um, Now it's 8 years. However, because this is such a new thing, it's always been 5 years. I tell my patients, if you didn't have any bleeding at all, and then all of a sudden you start bleeding, it might be that the coil has moved slightly. It might be that the coil is no longer serving you as a contraceptive and you might need to get it changed. Okay, so I would encourage you to go and see your doctor. And what I expect the doctor to do is examine you, check that they can still see the threads. They might want to do some swabs and they might want to do an ultrasound scan because we want to make sure that it's still in the right place. Because if it has moved, that's one of the things that you can experience where it moves. So all of a sudden you start bleeding or you start experiencing pain. So please, it's a good idea because you said 6 years. So again, I don't know if you were on it for contraception. I don't know when it was put in, but if it's been there for, if you've had it for 6 years, we always told patients in the past to come back at 5 years. But because it's now licensed for 8, I'm just telling them at 5 years, if you start to notice any change, just come back and I'll do a scan to make sure it's still in the right place.
All right. So I have another question here. What are ovulation stripes for? Does it say you are ovulating?
Yes, so that's what they are for. Ovulation strips are for to give you an indication if you are ovulating or not. And as you can imagine, all these strips, I don't find them the most accurate. Okay, but it's supposed to help women who are trying to track their cycle, who maybe are trying to conceive. So they want to know when the optimal time to have sexual intercourse is. That's why women will buy ovulation strips. And you remember I mentioned that during ovulation, your vaginal discharge will change. So those strips, it looks at the sort of the vaginal discharge as well to see if it's changed. That's really what it does. It just checks the discharge to see if it's changed and to see if you are ovulating.
Okay. Oh, this is my question. Thank you. Yeah, so PSP is so enriching and full of useful information. If you are not part of us, then tell me what are you waiting for? If you're in the UK, this is a safe community and we would like to have you in our community. So if you're interested in joining, see the link there. And okay, I have another question now. Had an IUD for a few weeks and it moved. Had to take it out, but since then I have had an irregular cycle.
Okay. So I guess I want to know how long it has been because sometimes you might have an irregular cycle after you remove it. And again, that's a good question because I think this will be a good time to go back to the doctor, especially if you notice that it has been irregular for 3 months. So let's just say we gave it 3 months to see if your cycles became regular. And if it's still not regular, then it's a good time to go to the doctor to find out, what's going on. So they will probably ask you a few more questions. They might want to examine you And then the fact that it moved, you're just wondering, did it did it scrape some of the lining of your womb, during that time? It's just wanting to know why. Okay, so it's difficult for me to say what has happened in your case, but I think it's a good idea to go to the doctor to find out what happened. If it was a marina, for example, that's the hormonal one, then I'm just thinking, if you only had it for 6 weeks, I wouldn't expect that to change your menstrual cycle. So there might be something else going on. So please go back to the doctor and just ask some more questions.
I can't see another question here. Please drop in your question. We still have some time. Now that we have Doc here, she's a very busy professional. So please let's maximize this time. Thank you. It's a quite insightful and educative. Thank you so much. Amazing presentation. Thank you, Doctor. Thank you,
Thank you.
Doctor. So please, we're still waiting for your question before we call it a day. So for those that are just joining us or joined later when the session started, so this program is powered by PSP UK. That's Parents Supporting Parents in the UK, and it's a safe community for parents, African parents in the UK, where we share educative and we share knowledge, we collaborate, we share various information ranging from different topics. I mean, today we're talking about health. Last time we talked about insurance and mortgage. We've had conversations around family finance. We've had conversation around sex and marriage, about demystifying British education system. I mean, we have a whole lot of questions, and you're free to ask any random question on the group. You sure have someone to respond to you. And so, if you're in the UK or you know someone in the UK that is struggling or would really need this kind of support, please do well to send that link to them, or you scan the QR code and share with them. Note, they have to join with a UK number, as we don't allow other foreign numbers, I mean, just for security purpose. So please do it to share. And please, if you are on this stream, please like and subscribe to this YouTube channel. Just help us so that we can reach out to more people. Our information are going out for free, but it will be nice. I'm sure it's going to help or even be a lifesaver to someone. I've had various testimonies of someone that just stumbled on our YouTube channel, and that was just an answer to their prayer. So please do it to like, subscribe, share the link, share our flyers, share everything we do with people you genuinely love. And also, just to mention, we are on Facebook and we're on Instagram at PSPIUK. Please do well to follow us on Facebook and Instagram. And shortly, we are coming on TikTok. And so please do well to follow us. Let this video go viral. You don't know whose life you might be changing. You don't know whose prayer you might be answering. I think I have a couple of questions in here now. Someone is asking, from your presentation, it shows that having a period makes one aware of issues quickly. What happens when one is using a contraception that stops period? How do you pick up on changes happening?
That's a very good question. So, contraceptives, now, the thing with hormonal contraception is that there are going to be some of them that stop your period. And the only way that you can know if there's something going on is if something changes. So when you get used to using a form of contraception and you've spoken to the doctor and they've told you what to expect, then when something is out of that, when something happens that's out of what they told you to expect, then that's how you know that something is going on. For example, with the Mirena IUS. So I will usually tell my patients that you either will have reduced periods, which is what happens in majority of women. Your periods the heaviness will reduce, so it becomes lighter. After 1 year, some women will have no period at all. If you've been going all along, no periods, when something now starts, that's an indication to go and speak to your doctor, like I mentioned in answer to the question earlier. If, for example, you've been told that the progesterone only pill will cause either your periods to stop or cause you to have spotting or irregular bleeding, if that's what happens to you, then you know that it's unlikely that there's something going on, unless something changes again. So I understand the logic of the question, and I can imagine that you're thinking, well, why would I want something that stops my period and I won't know what's going on? But just trust your body. Your body will get adjusted to having the Mirena coil in there. And if anything changes that's out of the ordinary, then that's when you go and see the doctor. And that's why it's so important. Just going back to the cervical screening, that every 3 years, just having that opportunity to see a healthcare professional that will ask you questions and examine you. That's a good opportunity that we can catch, females who are going through things that they had no idea about. Okay, same thing with breast cancer screening. Again, we can't just get everybody to have a mammogram or an ultrasound scan. But as you're checking yourself, as you're sort of being aware of your own body, then when something goes wrong, you go back to the doctor.
Yeah. Thank you so much, Doc. Someone is saying this was so insightful. Thank you. I have another question. What ad what is advice? What advice would you give for someone with dermoid cords?
So I
Yes.
think what they meant, maybe it was autocorrect. I think they meant dermoid cysts. I think that's
Okay.
what they meant. So dermoid cysts are cysts that can appear on the ovary. Okay. Now dermoid cysts they're not filled with fluid. They're usually filled with things like hair and other things. So we always want to refer them to the gynecologist. Okay. Because dermoid cysts can grow quite big and they can cause problems in the future. So what I always do when I do a scan and we can see a dermoid cyst, I usually refer the patient to the gynecologist. The gynecologist would usually want to observe them. They don't always remove it, but they might ask the GP to repeat the scan in another 6 months or 12 months. And we always want to do a blood test called a CA125. It's an ovarian tumor marker, which means that if it's high, there's a likelihood that the person might get ovarian or might have cancer. Okay, so it's always important that if you've been told that you have a dermoid cyst, that if they have not referred you to the gynecologist, you go back to your GP and just say, I want to see a gynecologist, okay? Because the gynecologists are the ones that can remove the cyst. However, they don't always remove it immediately. They might want to keep doing scans to see if it's growing before they remove it.
Thank you, Dr. Aditona. I have another question here. Can contraceptive injection, Sana press precisely cause PCOS, sorry.
So contraceptive injections, again, that's I think the brand name that you mentioned, I have to say, I've not seen any research that shows that contraceptive injections cause PCOS. Now, contraceptive injections can also cause irregular periods, and they can cause you to have to stop your periods. Okay, so if that happens, that is something that can happen. So the doctor or the nurse who puts you on the injection would have told you that your periods might become irregular or your periods might stop. So once you're aware of that information, if you start to notice that, and then you want to have children in the future, like I've mentioned, the injection can delay fertility even when you stop it. So it's not one that I would advise for women who are thinking that they want to have children soon. Okay, but there's no research that says that it causes PCOS.
All right. Wow, so insightful. I have another question here. What are the causes of high prolactin level and can it be treated?
Okay, so good question. So high prolactin levels, now sometimes it can be caused by a tumor, okay, in the brain. So if you go for a test, and it's a blood test that we tend to request when we're trying to find out why women are having irregular periods or why they're not able to conceive. And I have to say, it's when it comes to high levels, I usually refer patients. So it's beyond my expertise. Usually, I would be referring these patients. If they find a tumor, not all tumors are cancerous, so they might find a benign tumor that's causing it. If that's the case, then they will remove the tumor to try and help. Okay, but then there are certain medications that are prescribed by specialists that can also help to reduce your prolactin level. But high prolactin levels can be a cause of infertility. And usually, if I see that in my clinic, I just do a referral to a specialist. Okay.
Alrighty, this is so insightful. Thank you very much. Okay, please, if you still have questions, please go ahead and pop in popping. So just a follow-up question to the galactorrhea hyperprolactinemia. What if there has been a scan, there's no tumor? So what other factors do you think could have caused it? Is it hereditary? Is it, I mean, what else could have caused it?
Yeah. So sometimes the medications that the patient is taking can cause it. So there are some patients on antipsychotic medication that can lead to high prolactin levels. So it could be medication. Again, when it comes to genetics, you can never say never. So sometimes it could be hereditary as well. However, high prolactin levels are not normal. So usually there is something going on. But the ones I see commonly are as a result of antipsychotic medication. So the ones where they've had a scan and we don't find anything, a lot of times is down to the medication that the patient is taking. So those are some of the other common causes of high prolactin levels. But again, there's none of them that I would just treat myself as a GP. I would always refer to an endocrinologist so that they can do some more specific tests to find out what is causing it. But yes, the patients on antipsychotics, I see that more commonly because I refer them and then I get a response that they've done all the tests and they think it's the medication. So the question is, do we stop the medication? Or if the patient is not at that phase where they want to conceive, then we just leave them on the medication until they are ready to do so.
All righty. All right, thank you so much. I'm still looking out for questions in the comment section. If we don't have any, then we might have to call it a day. So
I want to say thank you to, I can see some of my family members in the comment section. So thank you so much for joining.
Thank you for coming out to share your love to our doctor. Thank you. I'm just scrolling through again to be sure that I've captured all the questions in here. Okay. Okay, I think I've captured them. Please, if you have questions I have not asked, please just point me out to it or you post it again. So thank you for being part of the please to blink. And just for you to know that you can always catch a replay with the same link with which you used to join. So probably you listen to it while busy doing other thing and you just want to take your time, sit down with it again. So you can always use that link with which you joined. You can use the link again to listen to it. And please can also share the link to people around you, people you know would really love this kind of information. Freely have you received, freely shall you give. So please share it, spread the word to everyone around you. Information is power. You don't know what that information you have shared with someone, you don't know how liberating it might be for the person. So please don't hoard information. And like I said, like, share, subscribe so that when we come online, you have access to you get a notification. And please, we are also on Instagram and Facebook. Please do well to support the ministry and follow us, like and share also. Let me see if I have. Oh, okay. Thank you, Adela. Thank you, Dr. Anu and the PSP team for always showing up with useful information and webinars. Thanks, everyone. Thank you. Thank you. Thank you so much, our beautiful Dr. Anu. God bless you richly. Amen. All right. So if there are no other questions, I think I can allow Dr. Anu go. And please, if you have any other questions or you would like to speak with her privately, if you're on the PSP group, I'm going to tag our number. Doc, they are free to reach out to you, right? As per we now. Okay, so that's a special privilege you have being a member of the PSP. You have direct access to Doc. But if not, and you don't want to join us, I don't know why, but so please, that's our Instagram and you can reach out to her, send her a DM, and she would gladly respond. Thank you so much, Doctor, for honoring our invitation.
Thank you so much.
We love you, we celebrate you, we appreciate you. Thank you for your time. We do not take you for granted. And thank you to everyone that has participated, that has joined, that has shared, that have asked questions, that has made it interactive. Because if you guys didn't show up, she'll just be speaking. But thank you also for showing up, and I'm sure you really enjoyed this session. I'm sure it was value for your time. And so we call it a day here until the next webinar, which will be communicated daily on the group. I have an amazing weekend and enjoy the rest of the weekend, enjoy the rest of the evening. Thank you, everyone. Thank you and
Thank
cheers.
you.
Bye.
Bye-bye.
So I end the stream in the next 5, 4, 3, 2, 1. Cheers, everyone.